All right, everybody. Welcome to PRS Global Open's Deep Cuts podcast. This is Leveling Up live at ASPS in San Diego. I've here Dr. Jason Ko. I'm Puru Nagarkar, your host. So let me introduce Dr. Ko first. Dr. Jason Ko is a professor of plastic surgery with an additional appointment in the Department of Orthopedic Surgery at Northwestern University Feinberg School of Medicine. He completed medical school at Duke University and then plastic surgery training at Northwestern University under the tutelage of Dr. Greg Dumanian. Dr. Ko went on to complete a hand and microvascular surgery fellowship at the University of Washington in Seattle and then spent additional time at Changgung Memorial Hospital in Taiwan as well as the University of Tokyo. Joined the faculty at the University of Washington in 2012 and then was recruited back to Northwestern in 2016, where he's currently the program director of the plastic surgery residency. He received his MBA from Northwestern's Kellogg School of Business in 2019, and since then he's become the vice chair of clinical operations for the Department of Surgery at Northwestern and is involved with many administrative roles within the hospital and health system. And he has served as the associate editor for the Journal of Hand Surgery, as well as the current research director for the Journal of Orthoplastic Surgery. He's also the co-program chair for the upcoming AAPS annual meeting, along with Dr. John Kim. And he has a practice focused on brachial plexus, peripheral nerve surgery, vascularized bone, upper and lower extremity reconstruction, amputee care, and TMR. So it's quite a mouthful. That's a lot of stuff. Welcome, Dr. Ko.
Thank you, Puru. Thanks to PRS Go for this fun session we're about to have.
Absolutely. So, that's a lot of topics that we can cover in terms of your practice. It's broad and very interesting, but I kind of want to start with the last one, which is TMR. So in the big scheme of things, TMR is still pretty new, and it's only been around for just over 20 years. And from the perspective of it being used to treat neuroma pain, that's even newer. It's only about 10 years. And most interestingly, you've been kind of involved with it from the very beginning. So I kind of want to start with that. How, when you look back 10 years ago to how you were doing TMR and how it was invented to the way you're doing it today, have you changed what you do? What's your approach? Do you feel like your technique has evolved a lot?
That's a great question. So TMR, it's funny. So Greg Dumanian and Todd Kuiken invented TMR at Northwestern back in 2003, so it has been just over 20 years. And Dr. Dumanian talked about at the time that he was doing this, and the concept was mainly for trying to provide new signals for advanced bionic prostheses. And he talks about how at the time doing the first surgery, his chief resident was, the entire case was like, this is the stupidest thing I've ever seen. This is never going to work. This is the dumbest thing ever. And then it did work. And
do we have a name for that chief resident?
Yeah, I'll...
Okay. Right.
He ended up being a chief of plastic surgery at another institution and very accomplished. But, I think it was just so kind of bizarre concepts. But when you think about it, back then, 20 years ago, the concept of nerve transfers were still relatively new. Now we take it for granted, like, oh, nerve transfer, no big problem. And so I think, Greg Dumanian had the foresight to say, like, hey, if we just create these new signals, then we leave it up to the prosthetics and engineer folks to figure it out. And so I do think prior to TMR in 2003, 2004, the whole neuroprosthetics industry it existed, but I think TMR then created these new signals, and then the neuroprosthetics industry exploded. But then again, everyone just thought it was kind of this weird thing, only hand surgeons or nerve surgeons do it. It wasn't until 2014 when we had our paper in CORE, Clinical Orthopedics Related Research, where we looked retrospectively at our neuroma pain patients. So patients anecdotally were saying, hey, when I had my amputation, I used to have a lot of phantom pain, a lot of nerve pain, can't wear my prosthetic. Now I had TMR and that pain went away. So we actually looked at it retrospectively, demonstrating that these patients do seem to get better, and realistically, day to day, they're actually wearing their prostheses longer, which is good. We did some animal work looking into it too. We were fortunate to get funding from the Department of Defense to do a multi-center clinical trial. And so we demonstrated with a randomized controlled trial that hey, if you do TMR in patients with existing pain, they will actually get better. Their phantom limb pain will go down, neuroma pain will go down. And then we took it a step further with Ian Valerio and our neuroma group. If you actually do it at the time of the amputation or within a few weeks, those patients probably will never get neuroma pain or phantom limb pain. And so it wasn't until the pain aspects of TMR that it really exploded. Now it's being done all over the world, upper extremity, lower extremity. We now do TMR in non-amputees, so any neuroma that we can't reconstruct, we'll do TMR. I talked about it in the morning session too. If I'm taking a sural nerve graft or any type of sensory nerve graft, because I'm so worried about neuroma, I'll do TMR to that proximal end.
Oh, nice. So when you do a sural nerve cable graft or something like that, you take that proximal end of the nerve and you put it into a gastroc branch or something like that?
Yeah.
Nice.
I also talked about how in the previous session, I try not to use sensory nerve grafts when possible. We'll use motor nerve grafts more often for short gaps. So.
Yeah. What do you go for? If you need like if you need a long one, you still have to go with the sensory. But if you have a short one, you can. Yeah.
So I do a decent amount of brachial plexus surgery. So if I need a long graft, I'm still doing sural nerve grafts and then doing TMR to the proximal end. But for shorter nerve gaps, when you think about all of the muscle flaps that we do, let's say you're doing a latissimus flap and you get to the thoracodorsal nerve, you just cut the nerve, or gracilis muscle, you're cutting the obturator nerve. Those patients, as far as we know, never really complain about neuroma pain. And so you can take a motor nerve graft. My go-to is the motor nerve graft to the vastus lateralis. So you make an incision like you would for any ALT flap. You have to cut that nerve most of the time when doing an ALT flap anyway. You can get 12 centimeter long motor nerve graft to the vastus. Patients don't really complain of any weakness afterwards. Yeah. So that's what I use when I need shorter gap reconstruction. But again, if I need a longer one, sural nerve graft.
Still sural nerve, what about when it comes to, as you know, I talk to your residents and your former trainees to kind of learn from them what they learned from you. One of the things that was brought up a couple of times was that your approach, especially when it comes to doing immediate TMR for like lower extremity amputations at the same time as the amputation, is less regimented than perhaps it has been in the past, or as they see other people do it. Like it's a little more freestyle in terms of finding donor nerves and the target nerves. So talk about that. Is that something that's just developed over time where you've kind of gotten more comfortable with it, or?
So you're telling me my residents are telling you all the dirt. So what I would say is for transfemoral, so above knee amputations, we still pretty much, everybody does it. We had a consensus paper in PRS Go where each of the authors from different institutions have all done over 100 TMRs. And the consensus of the consensus paper is there's no consensus. We all do it very differently. We may do it differently from case to case. For above knee amputations, most people are doing TMR through a single incision on the posterior aspect of the thigh, so prone position, taking the sciatic nerve, splitting it, and then transferring it to the different hamstring muscles. I also do saphenous nerve and Hunter's canal in the supine position, so usually for orthoplastic approaches, we are doing the amputations with orthopedics. They'll do it in the supine position, and then they usually do a myoplasty or myodesis. Before we close the above knee, I'll do TMR of the saphenous nerve, usually to a motor branch of vastus medialis. Then we'll close, flip prone, and then do the sciatic. Whereas below knee amputations, I think the consensus is the best way to do a below knee TMR is in the prone position through the popliteal fossa, or a stocking seam incision between medial and lateral gastrocs. That's where you're going to have the most motor branches with the best size match. However, just the other day, this week, we did TMR, acute TMR in a below knee amputee. For whatever reason, anesthesia really did not want us to flip prone. Ended up doing it through the wound, which I prefer not to do, but that's where it's a little more freestyle.
Yeah.
Because you're just looking for targets. But typically I'm splitting the lateral, so there's a fish mouth that ortho has done. I'll split laterally and then flip up this skin flap. And then you're looking at the anterior and lateral compartments. Pretty easy to find the deep perineal nerve and the superficial perineal nerve. and then just finding motor points. The problem with doing TMR in the wound itself is those motor branches distally are just not as big. And you could argue that may not be true TMR because you're not denervating the whole muscle, you're just denervating a segment. I will say through the wound, when doing the tibial nerve, that's probably the one nerve that I think it really matters to get a good target. So I will dissect that up as proximally as possible to find FHL or FDL, like a true target.
Yeah.
Just makes it a little tougher to do through the wound itself.
Yeah.
But that's where it's a little more freestyle.
Sure.
I still do saphenous above the knee, the Hunter's Canal, because saphenous, there aren't many targets here for the saphenous nerve distal to the knee.
Yeah, so it's just easier to go up above the knee there. And
Yes.
And get it, Very reasonable. When you are doing the actual coaptation of the nerve, are you just suturing, gluing, both?
Again, so everyone asks questions about the size mismatch. I think there probably is a sweet spot. We don't know what it is, maybe 3-1, unclear. But we do worry a little bit about like axonal escape. So if you have a tibial nerve and you're going into the motor branch of the FHL, for example, it's a huge size mismatch. So in those situations, I do use suture, anywhere from 8-0 all the way to 6-0. So for the bigger nerves, 6-0 proline, taper needle, loops, no microscope. If I'm doing smaller TMR, then a lot of times I'll get the microscope in and we'll use 8-0 or even 9-0.
Sure.
I augment with fibrin glue. But with the tibial nerve, whenever possible, where there's a big size mismatch to minimize axonal escape, we'll take that coaptation, it looks pretty ugly, and then I'll bring it down to the target muscle and then suture to the epimysium of the muscle. Other authors have talked about TMRPNI or vascularized TMR, that type of thing, which again, same concepts, trying to get a segment of muscle that's denervated and hungry for nerves to grow into. You're trying to just direct all those nerves into that hungry muscle.
So the idea is any axons that do escape will go into the muscle rather than creating a neuroma that's going to be painful.
Correct.
Right. Okay, that makes a lot of sense. So when you are, helping residents do this case and directing them on nerve dissection, what's your, what do you see the mistakes that people tend to make in nerve dissection that you have to find yourself repeatedly correcting? Like every year, the residents come through, and every year you see the same things. What are the common kind of pitfalls that you have to teach people?
I think, so fortunately at Northwestern we do a lot of TMR, but again, when it's a little more freestyle, you really need to know your anatomy very well. I think the one thing that my residents will test, like I am hopefully in a nice way really focusing on dissection of nerves, dissection of vessels, trying to have efficiency of motion. I think a lot of trainees, even if they know the anatomy and they've done the surgeries, it's just kind of getting the reps in to really get good at dissecting out nerves, knowing like, oh, I know motor branches will be in this area, using intraoperative nerve stimulation to help identify those. We tend to use tourniquets for the distal TMRs, and so usually they know too, the tourniquet can only be up for like 45 minutes until you get a tourniquet neuropraxia, and so really trying to be mindful of that. You have to move fast, find your targets quickly. Right. So it's mainly just getting the reps in, trying to kind of teach technical things in terms of dissecting out nerves, dissecting out vessels without being too disruptive.
Well, what are those technical things? Like, what do you like to use? What, long tenotomies, Geralds, right angles? What do you use?
You name the three things that I use.
Okay.
That's like the only things I use.
Right.
So tenotomy scissors, Adson with teeth or Geralds with teeth, usually. And then once you identify your nerves or your motor targets, carefully dissect so you're not disrupting them. Because if you're too rough on those motor branches, they will stop stimulating in many cases. So dissecting those, getting a right angle, a fine right angle around it, and then a vessel loop. And then with the vessel loops, making sure you don't put clamps on them, using vascular clips just to hold them.
Right.
But again, I think bleeding also is something my residents probably hate, that I just hate bleeding. So we are carefully using bipolar and really trying to not do anything where there's a ton of blood in the field, because whether you're doing perforator flaps, like free flaps, or nerve dissections, and you're trying to look for specific small structures, if you have a lot of blood in the field, then it just kind of slows things down and makes it harder for you. I remember you mentioned after my fellowship, I spent a month at Changgung with Fu Chen Wei, and then a month at University of Tokyo with Koshima. With Fu Chen Wei, when he would do an ALT flap, it would take him 20 minutes to make the incision. Because he would make an incision of 5 centimeters, bovie carefully, get the scalpel, another 5 centimeters, bovie. Because the point is, if you have blood in your field, you will not see your perforator, you will not see your nerves, and so we try to be careful with that.
Put the time in up front so that afterwards you're not struggling. It's like
and then technical things that it's just not maybe totally intuitive how to dissect like tubular structures. So part of it is just coaching up residents that, hey, when you're looking for structures that you know go in a certain direction, try to dissect parallel to where you think you are, but then once you see them and you have that view in a window, then you can start spreading perpendicular to create space. So those are the things that I'm constantly talking to residents about.
Well, I mean, one of the, speaking on the idea of being able to dissect and find the nerves, where do you expect them to be? Obviously, your anatomy is very important, and knowledge of anatomy is very important. That's one of the things that was brought up many times, is that you're one of the few people that maybe still asks a lot of questions in the operating room, expects the residents to know about anatomy. So do you find that doing that, so it's one of those things where I feel like over time, maybe that's decreasing, how many attendings actually ask a lot of questions in the OR, perhaps. I still like doing it. So I'm wondering what your take on it is. Do you feel like it's still a very effective teaching kind of technique?
I do. I mean, I think that's how we were all brought up, Socratic method. Unfortunately, I think there's some med schools that do not allow attendings to ask the students questions. I think we have some Northwestern students and sub-Is. They know I ask a ton of questions. Hopefully I'm nice. And the residents know too. I think the point of that is, you will only get out of each surgery what you put into it before you even enter the operating room. So that's what I try to actually emphasize to the residents. It's not so much me trying to embarrass you. I'm trying to gauge, A, how prepared are you for this case? Meaning, because that will dictate how much I'm going to let you do or how capable you are. And selfishly, too, my residents will tell you, I'm often run around and it's crazy, so I need residents who are extremely well prepared and capable and able to do stuff, independently for bits and pieces. So
you can rely on them. Basically.
So you can rely on them. But I think knowledge of anatomy is key, because that's the key to all surgery. But it's not so much and my residents will tell you, I don't know all the nerves. Greg Dumanian, one of the best nerve surgeons in the world, as a resident, it was always funny because he would be like, I don't know what nerve that is, but there's always a nerve right here, so just be careful,
Right.
And that's kind of, you need to know that stuff to be a fast and efficient surgeon, and you need to know, I'm always telling residents too, hey, this part of the surgery, you're not going to hurt anything, this is where you go fast.
Right.
But once you get down to this certain layer, then you slow down because there's always a nerve right here, there's always a vessel right there, that sort of thing. And so I think it is, I would like to think it's effective to ask questions, to push the residents, asking them, and Greg Dumanian's great at this, what articles did you read for this case? Nowadays it's I watched this video and I watched that video. I'm but what did you read?
Right.
What did you actually read? And then again, I think it's important, students and residents, it's wonderful that they're videos. We didn't have that benefit back in the day, not that we're that old. But I think it's important to still read the articles and really try to think about bigger picture things. I always ask students and residents, why are we doing this surgery? Why are we here? What are the options? Yes, we're doing this technique, but what are the 3 other things we could do, and why do you think we do that? Because I think knowing that is, very important to then pick up the scalpel and effectively execute it. And then I think the more prepared residents and students are, the more comfortable I am letting them do stuff with graduated autonomy. And I think the residents will hopefully attest, like, I'm pretty good. I try to be good about letting residents operate.
Yeah.
And then to the students out there, if I'm torturing you with all these questions, it's because I care. If I didn't care, I would not ask you any questions.
So, it is interesting. I always feel like one of the differences between the good surgeons and the really, really good and great surgeons is it's almost like the sixth sense when you're operating with them, and they kind of see things a few steps before you do, right? They see the nerve before you've seen it. They've seen the vessel, they've seen the perforator that's going to bleed, they've seen the little thing that's going to bleed before you were even aware that it was there. And it's kind of like this development of this ability to see a couple of steps into the future. It feels like you've got this future sense, where I get the impression that it's a lot of just reps, maybe, or maybe it's anatomy. I mean, how do you see it? Like, how do you teach that to your residents? Is it just, hey, you got to struggle, you got to go through this surgery 20 times, and you're going to hit the vessel a few times, and then you're going to know, hey, there's always a vessel there? Or is it possible to teach it? Because I always struggle with that.
Yeah, I mean, surgery, like many things in the world, it's all pattern recognition. So even in residency, I could tell as I graduated to the next PGY year, like, oh, I'm getting better at recognizing tissue planes. And then I see it now as an educator. Some residents can see tissue planes better than others. Some can see, like, through all the fat or whatever, like, oh, there's a nerve right there.
Right.
Whether it's pattern recognition, you're just looking for that tiny red stripe of an epineurial vessel. That's all you need to know, like the nerve's there. So, again, I think I try to, because I'm aware that it's pattern recognition, I try to actually, like, tell residents, like, okay, this is where you're going to see this. Look for these structures. See this little stripe there? That's a nerve. And then you spread, sure enough, the nerve's right there. So, again, not every resident is created equal, not every attending or surgeon or student. I think you need to adapt your kind of educational style for each one. Yeah. And some residents come in and they, like, can see tissue planes and they can dissect it, and that's awesome as an educator because we can kind of sit back and kind of still help guide. Others need a little more guidance, which is fine. That's our jobs as educators. But
that makes sense, and I think the point of knowing your anatomy really well to be able to do that, and the interplay makes a lot of sense. There's this saying, or there's a guy named Robertson Davies, I think, who said, the eye only sees what the mind already comprehends. It's like, you can't see the anatomy if you haven't studied the anatomy. Like, in person, you're not going to see it until you know it, which makes a lot of sense what you're saying. Let's switch gears and talk about thoracic outlet syndrome. So I know we were talking yesterday, and you mentioned that this is kind of a newer part of your practice, a growing part of your practice. And so, back to the thing I was talking about earlier, which is I'm always most interested in how people's practice and technique changes. I find in my own practice that when I start doing something new, the learning curve is very steep in the beginning, and the changes come fast and furious in the beginning, where I try something and I say, hey, that didn't work as well as I would like, I'm going to change it. So when you look at your approach to thoracic outlet, what have you found that you have rapidly changed that didn't work as well as you would have thought it was going to work, or things that did work as well as you liked and you're continuing to do them? What does that look like now for you?
Yeah, so as we talked yesterday, so thoracic outlet syndrome is something I do. I take care of a lot of patients, whether I want to or not. I have a love-hate relationship with thoracic outlet syndrome. It's one of those challenging diagnoses where these patients, they have these issues and they've seen 30 doctors and people have told them you're crazy, and then they come and see me and I say, well, you're probably not crazy. I think you have this problem, and let's work it up and go from there. And so I started out, I've always done a good amount of brachial plexus surgery, and I do a lot of nerve surgery, and I'm a hand surgeon by training. And I started doing thoracic outlet surgery probably somewhere in that 2016 to 2018 range. And then it would kind of trickle in, doing a little bit there. Looking back, like, I was definitely not as aggressive with it as I am now. And even now, which, students and residents will attest, I'm doing 1 to 3 thoracic outlet decompressions a week, which is, again, way too much. And I enjoy it like so many other things in plastic surgery that I don't want to. But it's one of those things where, I had a nurse fly in from New England and normally gets all her care at the Harvard system, and she flew in to come see me, and I asked, like, why don't you go to one of the Harvard hospitals? You already... And she was like, oh, don't you know? You're like the guy on the Facebook thoracic outlet page that everyone's talking about you. So it's one of those things nowadays with tough diagnoses like thoracic outlet. There are all these support groups and websites, and everybody's talking. So now it's like flooding my clinics. We have to actually like limit how many thoracic outlet patients I can see. Because they're super complicated. They have 300-page medical records, and it's just it also is just tough. Each patient takes like 45 minutes to an hour. So with that said, now that I'm doing like so many of them, not totally by choice, I'm definitely a better like thoracic outlet surgeon than I was 5 years ago, because my understanding of where the anatomy is, what structures cause the problems, how much anterior scalene do I need to remove, and then I would say I used to be probably much more nervous about going all the way down to that T1 level, especially if we're looking at subclavian vessels and everything like that. I'm much more aggressive now. And I told Puru yesterday, I do a lot of bilaterals in like stage fashion, but one patient I did just a few days ago, I had done his contralateral side 2 years ago. And then I just did his other side this week, and I knew as I was doing the surgery, like, oh, I'm doing a much better job now really decompressing his thoracic outlet compared to even 2 years ago. So the point is, like, we're always learning. We're always hopefully being critical of our own results and our own techniques. I implore everyone to, like, write these things up, look at them with research, but also, the session before was operations I no longer do was the morning session I was a part of. And even in, like, 12 years of practice, there are things that I don't do anymore and I do totally different now. Yeah. Just because I've, even in a mid-career phase, I've learned a lot. So it's important to just constantly always be critical and learning and being critical of yourself and your results, because if you think you're just awesome and everyone's doing great and you're never going to change, then you probably won't be a successful surgeon.
Right. Can't grow if you're not assessing what you got wrong. But when you look at the fact that you've gotten, you said, more aggressive about how much scalene you're removing or how much dissection you're doing, is it that you were seeing results that you didn't like, or is it that you were worried and you're less worried now because you're more aware of the anatomy, or you're more comfortable with the anatomy, you're more comfortable with how much pressure you can put on things before it's a problem, and that kind of thing? Like, how much was driven by results that you didn't like versus just increasing comfort with the location you were operating in?
I think I would say all of the above. As I get more comfortable, I'm seeing more results and seeing some recurrences from early on where maybe I wasn't taking out as much anterior scalene as I do now. Yeah. I think there are different schools of thought with thoracic outlet syndrome. A lot of literature is in the vascular or even thoracic journals, and the mentality with them typically is just go right for that first rib, because the scalene's attached to the first rib. So they take out the first rib and then may or may not really do work on the scalene. But by taking out the first rib, a lot of surgeons think like that takes care of the problem. Right. But Greg Dumanian would say, why do you do thoracic outlet surgery? It never works. Right. It always comes back. That's my Greg Dumanian voice. And I think it's because if you don't take out the whole scalene, you have this big block of muscle that maybe is less tight, but it's still going to scar right on top of your nerves. And there are usually fibrous bands right on the nerves. There are vessels that are compressing. A lot of times on C7, they'll see vessels, big vessels coming right off the C7 kind of middle trunk, compressing, right off the subclavian vessels, compressing C7 middle trunk, that you always have to go after those. Yeah. So it's just, again, pattern recognition and knowing like, oh, there's usually vessels here that I have to release. And then down at CAT1, there's always more anterior scalene that we got to go after that is super tight.
Yeah, fair. Do you feel like your indications have changed as well as you've gone along?
I think, again, as I see more, I'm relying, and then at the Hand Society meeting last week, we had a panel on it, and I think all of the surgeons on the panel, orthopedic and plastics hand surgeons, we all agree that diagnosis is so difficult. Imaging is often negative. It's a diagnosis of exclusion. But I do rely so much on physical examination, and it sounds crazy, but patients with, and I'm often decompressing nerves in their arms too because of the double crush phenomenon, but they'll have imaging looking at their radial nerve at the radial tunnel that says it's normal, but I know I'm going to operate on them for other things, and I just very simply will squeeze their radial tunnel,
right,
and they'll scream, and then I'll squeeze the contralateral arm, and they're like, okay, and I think I'm applying equivalent pressure. I'm trying. But then in the end, like all the imaging I got, like I don't really even follow. I'm basing it more on physical exam, where they're complaining. And so I do think, again, as I've seen so many patients, we're trying to write this up. Juliana knows probably like 130 patients, 140 patients, something like that. So I think just seeing so many of them, and I see so many in clinic that never even like make it to my OR, but I'm just getting better at diagnosing things and knowing like which tests to get and who needs imaging, who doesn't need imaging.
Yeah, makes sense. Let's switch to talking about free flaps. I know you do a lot of orthoplastic reconstruction, sarcoma, and trauma as well. One of the things that several of your residents said was, when they're doing these big cases with you, it somehow doesn't feel like a big case. It just seems to be not as stressful or go smoothly. And I wonder what you do to make these cases that might be big and stressful not feel big and stressful. Is there something you do in terms of how you prepare, or is it just the attitude in the OR? What do you think it is?
That's an interesting comment that they've made. I think, big cases are always big cases and they're stressful. I still, 12 years into practice, I like getting, maybe not nervous is not the right word, but like I am preparing and I'm getting ready for this huge free flap we're doing tomorrow. So I'm still reading, I'm watching videos, I'm mapping it out, sometimes drawing things out. I do try to like engage the residents in that process, because the more prepared everybody is in the room, and I've been doing this since Seattle days, like I will send articles to residents ahead of time and they're very appreciative, but it's selfishly because I also need them to be like, we need to be in sync for this to go well. We don't have fellows at Northwestern. For many years I wasn't doing free flaps with a co-surgeon, so I needed the chief resident to be able to elevate an ALT flap with minimal supervision. And so luckily we have that type of program where I think the residents are able to operate like, wizards, which is great. I do have a younger partner, Lindsay Janes, who's been amazing, and we've been doing co-surging, and I realized like, oh my God, my life's so much better with the co-surging.
Right.
But it's fun. I think the attitude is fun, and it's interesting because residents will ask, and I will tell them like, I am comfortable with residents kind of working independently in free flaps as long as we agree on the plan and we do the markings together and we do it because I trust them that they can do stuff, and then I also trust, hopefully, that they can't really get into too much trouble that we can't figure out how to bail out or have plan B, and we usually have discussed plans B and C. The funny thing is, like, the one surgery I will never let, like, I always have to have my hands on the patient is the simplest surgery. It's endoscopic carpal tunnel release.
Yeah, that's right.
I will never not have my hands on the patient during an endocarpal tunnel release because it's a tiny surgery. But if you screw up, it's really bad. There's no going back. And then, we talked a little bit yesterday, because I'm doing so much thoracic outlet syndrome. The reason I say, like, I hate it because it's so stressful and high stakes. These patients come in with pain, and they come to you and they trust you to like help them with their pain. But if you do one wrong thing in that surgery, like you've kind of made things 100 times worse. So that's another surgery where unfortunately, like I need to essentially be there the whole time doing the stuff. So it's one of these things where like free flaps, ironically, hey, I love microsurgery. It's still my passion over hand surgery or anything else. I think free flaps are fun. It's definitely a team sport. And like let's do the stuff, and if we mess up, we'll fix it. Whereas some of these smaller surgeries, or thoracic outlets, like a bigger surgery, you really can't mess up. And
well, I guess it goes back to what you said about can the residents do something that you can fix and undo, and cutting a nerve is not one of those things that is immediately undone, right? Yeah, sure you can fix it, but the problem is now caused, and it's not going to get better immediately. So that makes a lot of sense. It's funny that you say that about carpal tunnel. This is one of the things that for me is a recurring theme. Is I always feel that the big surgeries, the big cases, get a lot of our focus. Like at the meetings and papers, we're always talking about the big new thing. But often it's the little things, the small surgeries, the ones that are simple, the ones that are, this is an intern surgery, this is a second-year surgery, that have little nuances that are important, and there's a lot of stuff to learn there. And so one, for me, that I always find interesting is pinning. Because pinning, I find, looks easy, but it's really hard. So when I was a resident, I felt, it's harder to do than it looks. Now that I'm attending, and I'm teaching residents for the last many years, I feel like it's actually harder to teach as well. It's not easy to teach it either. And so I'm wondering how you go about teaching people to be good at pinning, because I struggle with that.
I agree. I still struggle with pinning sometimes. I think as plastic surgeons, we just don't get as much exposure to using K-wires and drills. We do to a certain extent. It goes back to kind of why I even became a hand surgeon. I always wanted to do microsurgery fellowship. I knew I was going to go to Chang'an or wherever, maybe MD Anderson. And it was Greg Dumanian who said, you need to do a hand surgery fellowship. And I said, I don't even like hand that much. He's like, but I always wanted to do orthoplastic, extremity reconstruction. I love nerve surgery, vascular reconstruction. He said, at Northwestern, we do so much microsurgery, so much nerve surgery. We do vascular reconstructions for ischemia. The one thing that most plastic surgery residents do not get much exposure to is orthopedic hand surgery, how to fix fractures, how to put in K-wires, drilling bones, plates and screws, that sort of thing. So if you want to be a total badass, you need to do an orthopedic hand fellowship. And he had me at badass, and I think he knew that's kind of what I needed to hear, because if you can take care of bones and fractures, then there's no problem that comes through your door that you can't take care of. And so going back to K-wires, unfortunately, some people are more inherently able to do K-wires. I think there's three-dimensional visual spatial skills that some people possess, others have less of. I do think there may be some correlation with video games and stuff, or sports and musical instruments, that type of thing. But again, K-wires, it's all about reps.
Yeah.
As plastic surgery residents, we just don't do that many, and so it's hard to get good practice. I'm sure there's a model out there where people are using fluoroscopy with sawbones and trying to get better at it, but it's just practice. And even I get frustrated with K-wires, because K-wires can definitely make you look like not a good surgeon, including me. Resident will be struggling, and I'll give the resident a hard time, and then I'll grab the K-wire driver, and then I'll start struggling, and I'll be like, oh, yeah, I mean, something's wrong with this patient. It's,
for me, this was, one of the reasons this podcast is called Leveling Up was an experience I had with K-wires, actually, because I remember I was a second year, and I was trying to put K-wires in, and just struggling exactly like you described, and the attending took it from me, and just, bam, it was perfect, right? It's like, great, I suck, I feel terrible. But I came back a couple of years later, having not done any hand surgery in the middle, because that's how our rotations work, and all of a sudden I could do K-wires, and they were fine. They were going in perfectly. And to me, it was always kind of this interesting thing about the improvement in your visual spatial assessment of the hand, even though you weren't putting in K-wires during that time, it improves, and then all of a sudden you can do it. But the thing I struggle with is, teaching it seems really hard, and maybe it's just reps and just time.
Yeah, I do think it's reps and, just reminding residents that even a small change in angulation will make a big difference on the x-ray, and the x-rays are always magnified. The K-wires are probably like the most frustrating things as hand surgeons that we do.
So, speaking of teaching and residents, one of the things that your residents all spoke very highly of was just your ability to be very even-keeled and give good feedback in the operating room, immediate feedback. But there was a funny story that one of them told about a time that they were pinning actually with you. You want to tell us what happened?
Sure. So one of my senior residents, we were doing a very tough comminuted distal radius fracture where you can use like multiple plates. So we were putting on like 4 plates, if I recall, through multiple incisions to fix this distal radius fracture. It relies on a lot of K-wiring to hold the plates, hold the bones. And so I remember this senior resident on the hand rotation who's excellent, and, becoming famous hand surgeon out there. I was like, okay, so I'm holding the bone. A lot of times, Puru knows, I have to hold the reduction in place because if I let go, everything just falls apart, right? So I'm holding the bones, and I'm like, hey, can you just put a K-wire like from here to here? Okay. Boom, right into my hand. And I was like, ah! And again, I do think I tend to be even-keeled. However, I think my residents have all seen me kind of, get angry about certain things. But this, you can imagine, I was really not happy about. Because again, I'm holding it, and he just went right into my hand.
Right.
Like, how does that even happen? So I lose it, whatever. We have to do the whole occupational health thing. I scrub back in, and I'm like, okay, let's try again. I'm holding the bone. You really got to get this K-wire right through here. Like, okay, you got it? I got it. Boom, right into my hand again. Probably one of the few times I've lost my temper in the OR, but I think that's understandable. Everyone would agree.
I think it's excusable, yeah.
Anyway, that person went on to go to a top hand fellowship, is now a fairly well-known, young future leader in the hand surgery world, and ended up, actually, I wrote in their fellowship recommendation letter that otherwise he was one of the best at putting in K-wires I've ever seen when it wasn't going through my finger.
Your finger, yeah. Well, the funny thing he said was that after all this, and you were so mad, but the next day when he saw you again, it was like nothing had ever happened. Everything was just fine. And so that's the part that I think he really appreciated, and I thought that was the best part of the story. All right, well, we're running short on time here. One of the things that I always like to talk about before we finish is to talk about mentors and the people who've taught you, because that's what this podcast is all about. It's about learning. So I know I have the words of my mentors. Anytime I'm doing a case, I'm working with a resident, I'm always telling them things, and I'm saying, Dr. Jeff Genkel told me this, and this is really interesting, or whatever. I'm always repeating things that my mentors taught me, and they're just running through my head. So I'm wondering, what are the words of your mentors that run through your head that you repeat to your residents or to yourself?
Yeah. Well, it's a little bit cheating because I did residency in Northwestern, and Greg Dumanian was my program director, and now I'm back in Northwestern. I'm the program director. He's my boss. And so we still are talking all the time, and I'm always hearing his voice kind of in real time. But I think one of the things that I talk about in my orthoplastic talks and vascularized bone talks, it's a quote that I like to use, is you must attack big problems with overwhelming force. And it's this concept of, we in plastic surgery, we learn about the reconstructive ladder and hey, you should try these pedicle flaps before you do these free flaps. But in reality, in orthoplastics, it's probably finally now in 2024, people are realizing, hey, the reconstructive ladder is probably not the best thing. You should just jump on the elevator like Larry Gottlieb said, go right to the free flap. rather than torturing the patient with multiple failed pedicle flaps. And so this concept of, big problems deserve overwhelming force. Big problems require even bigger solutions.
Yeah.
Don't cut corners. Really don't try to get away with this little flap and hopefully that tip will cover what you need. Just go big or go home for the most part.
Shock and awe.
Yeah. And then other mentors in hand surgery, Doug Hanel, Nick Vetter, Tom Wiedrich, Dan Nagel. I think the emphasis with hand surgery is we talked about anatomy. Hand surgery, probably more than anything, you really have to know your anatomy. If you know your anatomy, then you can do a good physical exam and diagnosis. We used to call Doug Hanel Google because we'd say, hey, Dr. Hanel, what's this, blah, blah, blah. And he'll cite some paper from 1976 because that's what he's able to do. I'm incapable of that type of thing, but I think that's one thing I learned from my hand surgery mentors / partners, that they are so focused on hand, they know everything about the literature and everything about the anatomy, and it's something to strive for that I still have not achieved, but always trying.
Fair. All right, before we end, last question. There was one thing that every single resident I spoke with mentioned about you. So you love 90s hip-hop, so what are your top 5? Top 3, maybe. We'll make it easy.
So I'm dating myself. So 90s, early 2000 hip-hop, in the OR, just because it's a little more crowd-pleasing, kind of hip-hop barbecue type of stuff. But I listen to Nas, listen to Wu-Tang Clan, maybe not in the OR. Mos Def, Talib Kweli. Tribe Called Quest is more of a crowd pleaser.
Oh, sure, yeah.
But some of the stuff that, hopefully less cursing and everyone can appreciate.
Yeah.
But Tribe Called Quest playlist or radio station, that is usually pretty safe and generates good songs. So,
excellent. Well, Dr. Koh, thank you very much. Let's turn it over to the audience in case there's any questions.
Thank you, Puru.
Hi, my name's Keenan. I'm a medical student from Wayne State. Thank you guys for the talk. I had a question about donor site and recipient site nerve mismatch. Is the current practice to just go with a mismatch, or is there an ideal ratio between donor and recipient? And are there complications associated with the intraneural neurolysis?
So for TMR, donor, there's always going to be a mismatch between your donor nerve for the most part and your recipient or target nerve. There probably is a sweet spot or a minimum threshold of size mismatch. However, the very first TMR shoulder level disarticulation, you take those branches of the plexus and you are suturing them to tiny motor branches to the pec or the serratus. I don't think we know that answer. People have been trying to study it. With that said, we talked about it earlier where nowadays, because of the concern of the mismatch and whether you're going to get a neuroma at that nerve coaptation site, most of the surgeons now are trying to then do something to bring that nerve coaptation, the donor nerve, down to the target muscle so that you don't have as much axonal escape for that denervated muscle to absorb as many axons as possible. And other authors have used vascularized RPNI or TMRPNI or other things to try to minimize the axon escape, minimize the chance of neuroma formation. In terms of splitting the nerve, the only time I'm really splitting the nerve is sciatic TMR. And I think for then, a lot of it is, it sounds barbaric, but you're kind of pulling on it. And you can see with the cut end of the sciatic, you'll see 2 main fascicles, maybe a third one, that, okay, this is the tibial component, this is the common perineal component. And so you just split the epineurium, and then it kind of peels apart, and you can find your dissection through that without much disruption when you're splitting that nerve.
String cheese.
Yeah. Or those, string cheese. Yeah. Exactly.
Yep. Thank you for your answer. That was very thorough.
Yeah. Yep. Thanks.
Thank you so much for your talk, Dr. Koh. As an attending and many years into practice, what are your ways that you like to keep What are ways you like to keep your practice and techniques fresh and continue learning?
Thank you, Adure. Adure is one of our amazing Northwestern residents. I don't know who planted you in the crowd. I think, again, if you're going into plastic surgery, you got to love surgery. I do love surgery. We tend to go into plastic surgery because we're creative and innovative and we always want to try new things. And so it's coming to meetings like this, going to microsurgery meetings all around the world. I'm learning new techniques all the time. My advice to the trainees and the students, and the reason why after my fellowship I knew I always wanted to go to Changgung to see plexus. That kind of was my first real exposure to brachial plexus surgery with David Chuang, and that demystified. We talked about it a little bit yesterday, but I didn't do plexus in residency or fellowship, and I went to Changgung, and David Chuang does a plexus case a week, and it really demystified the neck. It's not as scary as I thought it was going to be. And then I went back to Seattle, the University of Washington, just started doing plexus with Raymond J. and Jeff Friedrich as mentors to help guide us, but built up the brachial plexus practice there. So I think you need to the students and trainees, I always tell residents, look, we have a research year too, so everyone wants to just go right into practice. And I'm just this is your last chance to get additional training. You will always appreciate additional training. And so I do think it's helpful to train as much as possible. And again, even after training, going to different institutions and learning has been very helpful. And then once you reach that phase of chief resident or fellow and you go to Changgung or Tokyo, you don't have to scrub to learn. You're watching, because you're able to do stuff better than when you were a junior resident, you're absorbing so much. So I think it's important to constantly learn, go to meetings, read journals, try new techniques, but being safe, and exposing yourself to new ideas and keeping an open mind.
Yeah, that's it. No, I have always found it interesting that the further you are into your practice, the easier in some ways it is to learn something new, because you can connect it to things you already know. And it becomes easier because, you can just watch something and learn it without needing a million reps to actually be able to do it for the first time. Because you've got more experience around that area even to be able to do it. So.
And I would say one of the benefits of working in academics too is I learn from the residents as much as they learn from me. And we try to have a two-way dialogue about hey, here's this crazy case that needs a free flap. And Greg Dumanian's the best. He would always say when we were residents, tell me 6 different ways to reconstruct this. And so I try to engage the residents too, this is what I'm thinking, what are you thinking, or usually I ask the residents first, what are you thinking? And sometimes it's totally different than what I'm thinking. And then we talk about it and come up with a plan together. And residents have said, hey, I saw, this other talk at a meeting with this technique, or I read this paper, can we try this? And I'm all right, let's try it. So usually that's the benefit, too, of being in academics. It's I'm constantly learning, as you are, Puru. We're learning from our mentor, or our peers, from our residents, from med students even, kind of bringing new ideas to us and keeping things fresh.
Yeah. Oh, fantastic. I don't think we have any more questions. So once again, Dr. Ko, thank you. That was awesome conversation. I feel like I learned a lot, and hopefully I can start doing some things that you're doing and learn from doing them too.
Thank you, Puru. Thank you, PRS Go, and everyone enjoy the meeting.